Hello, everybody. My name is Rebecca Jamwal. I'd like to thank the organising committee for inviting me to speak at the Gerentech and Innovation Summit. I'm really excited to be sharing Australian work with you around smart home and communication technology for people with disability. Before we begin, I firstly want to acknowledge that I live and work on the unceded lands of the people of the Kulin Nation and pay my respects to their elders past and present. I also want to acknowledge that my work presented here today was produced on these lands. I also want to acknowledge that some of the work received funding from the Transport Accident Commission, who are one of the state-based funders of assistive technology where I live in Victoria, via the Institute for Safety, Compensation and Recovery Research. This is an overview of the next 20 minutes. My aim is not to give you all the information because we'd need longer than 20 minutes, but I will start by providing an overview of smart home and communication technologies in the Australian context with a short video. I'll then provide you with reference to literature describing the use and impact of smart home and communication technology for people with disability. We'll then talk about the success factors for implementation of technologies and briefly outline some recommendations on assistive technology research and how policy can enable equitable access to assistive technologies. So I want to start today by sharing this video that was produced during my PhD candidature and describes how smart home and communication technologies have been integrated into new accessible housing in the Australian context to promote tenants' independence.
I'm Talinga. I'm the TAC practice leader here at TAC Glenroy, and we've been operating since February 2016. The service objective here is working with each of the tenants in increasing their independence, their self-capacity building skills, and maximising their privacy. We've been able to do this by incorporating electronic assistive technologies, and this has helped reduce the dependence on carers over time. The experiences that some of the tenants have had here has been life-changing. They've been able to gain their independence back and their privacy, which has just made a massive impact in the quality of life that they have. Now that the tenants are using their integrated technology, we've found that they've just been able to increase their independence and gain control over their environments. They're calling on staff a lot less and they're gaining more independence and confidence within their own homes. So the tenants have a tablet device and a wallpad feature, and they're able to control their environments within the home, which do include the blinds, the lights, the doors. They also have emergency switches in some of the rooms, so they're able to call on staff, and we've just found that this has made a real difference to their independence. Some of our tenants were apprehensive about using the technology, and we needed to guide them and just train them and work with them in becoming familiar. So through repetition, the tenants were more comfortable using the devices and the automation equipment over time.
I think I enjoy the private time on my own or with my family now because I have more time. I can be independent and do what I want. I don't have to rely on another one to help me doing this and doing that. So I feel more happy now compared to what I was before. Yeah.
So one of the tenants we support here really values his privacy. He's actually in a full-time relationship and has a living partner. He's actually requested that all our communication be via either text or phone calls, and we respect that here at RDI. For the technology to be a success, we need to ensure that we're working collaboratively with each of the tenants in rectifying any issues that come up and in just ensuring that we're listening to the tenants when problems arise. So one of the tenants that we support here was really apprehensive about using the technology, but through just constant encouragement and repetition, he was able to gain the confidence in being able to navigate the system independently. We've been able to see a reduction for one tenant I have in mind. Actually, she's been able to gain her independence a lot more, and we're just finding that she's calling on staff a lot less. So when choosing a technical supplier who will be providing the technology within the units, I think it's really important that they're on board and they work in partnership with you, and that any issues or mishaps within the systems are resolved promptly, and this ensures a smooth transition and success with the tenant's use. A real difference that I've observed since coming to TAC Glenroy is just seeing the tenants just get their privacy back. A lot of the tenants have come from supported residential services or have been living with parents in their mid-30s. So I think, you know, the tenants coming in and just having their own environment, their own space, their own freedom has just been life-changing and has just brought back their quality of life that they had prior to having their accident.
So that case study highlights how smart home and communication technologies, referred to there as electronic assistive technologies, have been consciously harnessed in this housing, what we refer to in Australia as specialist disability accommodation, to promote the user's independence, capacity building, and to maximise their privacy, and the associated impacts this has on the tenant's quality of life and their reduced dependence on other people. So Tilinga also spoke about some of the learnings made around what leads to successful integration of technology, which we will come back to shortly. But I just wanted to flag that we do have more videos available to view via YouTube that describe 3 different people's lifetime experience and journey with the electronic assisted technology that I encourage you to have a look at. Okay, so in terms of electronic assistive technology that has been documented in the research literature, we've seen both mainstream and assistive devices used as assistive technology for cognition. My Australian colleagues, led by Professor Natasha Lannon, looked at the use of Google Calendar with people with traumatic brain injury. Her team developed a highly structured training program to teach clients how to use Google Calendar and found that using Google Calendar improved participants' ability to independently undertake planned tasks and activities. There was a systematic review and meta-analysis by Jamison and colleagues, which investigated cognitive prosthetic technology. The majority of people included in the studies reviewed benefited from technological memory aids, and therefore the review recommended the use of compensatory technology for patients experiencing memory impairment. We also had occupational therapists in Sweden using everyday technology or off-the-shelf devices to address individuals' occupation-based goals, including dictaphones, mobile phones, and handheld computers or PDAs, some of which were already owned by the clients themselves. And they found that these interventions were able to compensate for perceived difficulties following ABI, improve satisfaction with occupational performance, and their overall contentment with life. And for people with intellectual disability, Italian literature review highlighted that technology systems designed to present single-step instructions can be effective in teaching and supporting the independent performance of multi-step activities. And another paper by Randall and colleagues established the meal planner app's efficacy for increasing meal planning independence in the same group. We've also seen examples of augmentative and alternative communication documented, such as tablet devices with text-to-speech software for people with difficulty generating speech, as well as AACs that can be accessed via sensors for people with limited movement, such as those with locked-in syndrome. Raghavendra and colleagues have researched with young people with disability, including cerebral palsy and ABI, delivering one-on-one support and training to facilitate social participation through the internet. They found that their method was effective at increasing social participation, but noted that it was an intensive training program that may be difficult to replicate. We've also seen electronic assistive technology applied to leisure activities, with studies by Holes and Lancioni reporting positive engagement in social and leisure activities aided by technology use. Home automation and communication technologies in housing are receiving a lot of attention in the literature, and these are the systems, as we saw in the video, that allow the user to control their environment and call for assistance if needed. And sensor and monitoring technologies are also receiving a lot of attention, particularly for people with degenerative conditions such as dementia. So there's also examples of sensors being used to ensure medication compliance, monitoring potentially dangerous home appliances, and monitoring for unexpected changes in a person's routines or movements so that caregivers can be notified in case the person falls or experiences a medical episode. Again, my aim today isn't to tell you everything that exists out there, but I did run a search of the literature for what's come up since my group published this scoping review referenced on the slide, and there has been a lot published since, that scoping review does offer a useful starting point for those of you wishing to understand the current evidence base related to smart home and communication technology. So I'd encourage you to take a look. So knowing that electronic assistive technologies are advancing all the time and present such exciting possibilities for people with disability, I used my PhD to build an understanding of how this group were actually using technology. Part of my research involved interviewing 22 people with acquired brain injury living in supported accommodation, and we used 2 published measures, the PADS and the QUEST. So we recorded the interviews and analysed the transcripts to understand the themes of the participants' collective experience. And we found that electronic assistive technologies impacted these 4 areas. So life role participation, particularly that of maintaining key family roles such as parenting. They impacted the participants' sense of safety when accessing the community. They increased participants' sense of autonomy in activities of daily living. And they enabled communication with others. So these themes are very much aligned with the outcomes of the research included in the scoping review I just referred to. Enablers to technology use identified by the participants included experience using these technologies prior to their injury, design of devices and user interfaces that enhanced ease of use, and devices that supported multiple functions. While on the flip side, key barriers identified included the insufficient planning, consultation and support that was often experienced when a device was first obtained. We had examples of people abandoning light riders because they preferred to try and use their voice or use other methods of communicating, which really should have been identified by the therapy team in the prescription phase. Participants also identified that there was limited ongoing support available, so there was limited opportunities for this group to upskill in their tech use. So this research in the 2022 scoping review emphasised these 2 points, that adequate instructions, guidance, training and ongoing support are necessary when we supply new electronic assistive technology. And while design was identified as an enabler, it was also identified as a barrier for some participants. So for example, the small letters on smartphone keyboards and the slide to unlock feature were difficult for some participants to use. Unreliable or restricted internet access also impacted people's use. And this point was further emphasised in the scoping review, that the benefits of technology were really dependent on its reliability, with internet reliability being a key factor that can influence this. So given I didn't speak to caregivers as part of my PhD, it was interesting to see how the research included in the scoping review reported the impact of technology on carers. So Huang et al. Found that an eye tracking technology facilitated the user's access to the internet and ability to send emails, reduced caregiver burden. Corello et al. Reported that AAC allowed people with locked-in syndrome to have effective communication with their caregivers, which improved the family's wider well-being. And sensor-based technology was found to ease daily life for the caregiver and provide them with a sense of control over their caregiving role. However, some caregivers also reported an increased responsibility in ensuring the technology used was also maintained. In regard to user satisfaction, which we measured using the QUEST, participants were consistently less satisfied with the services they received in relation to the technology that they used, which includes information, maintenance, repairs, and so on, than they were with the devices themselves. And despite some of the barriers identified and the lower satisfaction rating for services received, the results of the psychosocial impact measure, the PADS, demonstrated that technology use positively impacted its users across all 3 domains measured by the scale seen there. And given the potential of technology that has been recognised, we thought we might find people using their electronic assistive technology as part of their therapies and support delivery, but they rarely were. So home automation technology installed at one participant's SSA had actually turned off as it had had a number of teething issues. So we didn't see the potential realised for this group of participants. So what does good practice look like? These good practice steps are outlined in the Australian Assistive Technology Equity Studies report, which is referenced on the slide there, and have been adapted from the 1994 European Heart Study and align very closely with what participants were telling us from the interviews. So the first step being around initiation, so providing an identifiable point of entry to the AT service system with clear, accurate and relevant information on what's available, and referral to appropriate assessment and or services to address identified needs, which leads into that second step of having access to funding for assessment in order to identify the assistive technology required. Once assessment is completed, trialling the AT in the environment it is likely to be used to promote retention and satisfaction. And once the solution is selected, minimising the red tape around procurement. So a great example of this was the recent change by Australia's national disability insurer, the National Disability Insurance Agency, to no longer requiring quotes for items that cost up to 15,000 Australian dollars. Rather, the individual simply needs to provide a letter from their AT assessor around why the equipment meets their needs and why it is the best option for them, rather than a formal assessment. Okay, so setting up assistive technology to fit the person and the environment is a further critical step, which, if not implemented, is linked to AT abandonment. The same goes for the delivery of training in assistive technology product use and training to maintain and troubleshoot the assistive technology. As we heard from the support provider in the video at the start of this presentation, we need to have good engagement with the technology provider to have issues promptly resolved. Good implementation practices ensure that there's funding available for both of those steps to take place. There also needs to be acknowledgement of the regular maintenance that assistive technology products require, whether this is servicing, battery replacement or refurbishment of wear and tear. Digital assistive technology requires updates to software and operating systems. And ultimately, some products have a lifespan and need to be replaced, whether this is like for like or to be upgraded to a newer model. So as I've recently discovered with my robot vacuum that's no longer working on my 5G home internet, sometimes the software outpaces the hardware and needs replacement. And that's where step 8 becomes relevant. So ensuring that there are clear review and replacement protocols in place that specify when assistive technology should be reviewed and replaced. In terms of directions for future research, currently there is insufficient rigorous research on the effectiveness of most assistive technology provision services and systems. We need this research to inform investment both in the technologies themselves, but just as importantly, the wraparound services we've been speaking about that promote successful technology use. So assessment, trialling devices and systems in the environment that they're to be used, supporting setup of the device once it's procured, and to receive training in its use and maintenance, and plans for reviewing use in the context of the AT lifecycle. And we want to see the AT sector upskilling in the collection of outcome data using tools such as the PADS and Quest in their practice so that we can add practice-based evidence to our collective knowledge. So when we completed the scoping review, we found that the outcomes examined by included studies varied and only 3 outcome variables were used across more than one study. So future research would benefit from using consistent measures, enabling comparisons across studies and systematic assessment of results relevant to the body of research. I want to point you really quickly to some communities of practice that you might find useful. A community of practice being a group who share a concern or a passion for something they do and learn how to do it better as they interact regularly. I'd really encourage you to take a look at ARATA's website. You can subscribe to their email listserv to post questions and connect with other AT practitioners. So ARATA published an issues statement regarding assistive technology provision in Australia that provides points on how an enabling policy environment can be achieved. Firstly, an enabling policy environment is one where there is awareness and recognition of the rights of people with disability to access assistive technology and the social and economic benefits to individuals and wider society. An enabling environment also offers, sorry, I just lost my spot. An enabling environment also offers sufficient resourcing and equitable access to assistive technology services that provide information, advice and support to finding and using quality of assistive solutions and products. What we want to see is equality. So each individual or group of people being given the same resources or opportunities, as well as equity, the recognition that each person has different circumstances and therefore will need different levels of resourcing to reach an equal outcome. By no means have we achieved that in Australia. My colleagues from ARATA had a paper published in the Australian Journal of Social Issues on the 26th of September, calling for national equitable access to assistive technology and home modifications. So this paper reported that there are 88 government funders of assistive technology and home modifications who administer 109 different schemes in Australia, which provide very different types and amounts of support. So one of the most striking examples in Australia is the differences in systems across geographic boundaries, particularly in relation to state and territory boundaries, which result in postcode lottery where people with similar needs receive different amounts of support based on where they live. So there's work to be done on that point in Australia, and coordination is also identified as essential to an enabling a policy environment. So ensuring that there are links between mainstream and specialised services that ensure that solutions can be tailored to an individual situation and that the end user is involved in all activities and decisions. Finally, as enabling policy environment sets agreed outcome benchmarks that meet human rights criteria and supports the WHO definition of human activity and participation, which is that access to assistive technology is a fundamental human right and legal obligation for all countries within the Convention of the Rights of Persons with Disabilities, and a prerequisite for the full and equitable achievement of the Sustainable Development Goals. So I wanted to finish off today with this passage, which I've taken from the scoping review I co-authored. We engaged a tech user with disability to act as an expert consultant on the review, and I think it summarises everything we've talked about today. That smart home technology, when implemented and supported effectively, has the potential to empower people with disabilities to live the life they desire. This may save government funding, allow for better allocation of support worker resources, and a true level of independence can be sustained and enjoyed. There's some references across these 3 slides and my contact information here. Thank you.
Let's welcome Rebecca. Hi, Rebecca. Thank you for being with us today. So let's see thank you. Let's see the questions from our audience online. So the first question is, some of the friends with disability are apprehensive about using technology. How to encourage and help them to adopt the use of technology?
Yeah, that's a really good question. I think that comes back to those wraparound supports that we talk about. So things like support when looking at different products, to select different products, going along to equipment providers to get an understanding of what's available out there. And then, of course, once you've chosen a product, learning how to use it. So taking that time to train in how to use it, seeking professionals' advice for any tips and strategies. And then also, once they've been using it for a while, just checking in with them and seeing whether it is still meeting their needs and whether it is in fact the right device and whether there may need to be a change or a new device explored.
Well, that's amazing. And you have highlighted how the customer experience, or how like the service provider or the product provider actually can gain the result from them, and then try to account for their experience, and then use into like renew or update the product, which is something that will be very amazing for customers to feel their value, and which the customers are the patient or the people with disability. Thank you. The next question is the question is, in line with the everybody tech philosophy, to what extent can the described technologies be accessible, usable, and useful to other special populations and the general public?
I haven't come across the everybody tech philosophy, but I think to what extent can they be accessible, useful, and useful? I think we're starting to see our mainstream providers and companies such as Apple integrating accessibility from the outset. So I think developers of technology are understanding that if they make their products accessible, they're going to be of interest and desirable for the customer to purchase. So I think that probably does sit with the developer in terms of understanding the market and making their devices as accessible as possible to everyone. And then also, again, going back to those wraparound supports, having the opportunity to trial different devices that are out there, looking for what meets your needs, and then having that evaluation process so that you can make decisions as to whether you need to look at a new solution or not.
Thank you. Yeah, I think that is actually in line with much of your work, and which helps you to update and also get the experience from the people with disability. And another question is, from your observation, how's the training outcome different compared at home and at centre?
Yeah, that's a really good point. So in Australia, we've We have, I guess, rehabilitation for people who acquire a new disability, where they'd be able to receive daily therapies from OTs, physios, speech pathologists, and so on, where they would be able to receive that guided practice perhaps on a daily basis. And then, of course, once people get home, they're not receiving that intensive support. There's often a wait between leaving hospital and your community therapy starting. So we're talking a matter of weeks before a community therapist might actually commence with someone, which is a problem in itself. So there could be some loss there between leaving hospital and getting home and community therapy starting in terms of using the technology in the home environment. So I think that is an issue. And I think having that opportunity to test different devices and solutions is probably trickier in the community when you don't have that intensive support from someone. So that is a barrier, I'd say.
I see. And yeah, that's possibly, even for Hong Kong, we need to work on that, how to support people who live at the community more than the people who probably stay more in the center or hospital. Another question from, apart from the 80 practitioners, users, suppliers, researchers, and the policymakers, what the community can do to advocate the implementation of assistive technology?
Yeah, I really think it's about awareness. So being aware that people with disability may need to access technology differently to you and I, and understanding that there are possibilities. There are ways that people can access the same devices that we use in different ways. So I do really think it's about awareness, which is why we produce those videos that are available on YouTube. So we show one person with vision impairment, all the different types of devices that they were using, which I wasn't aware of, the various devices that were available to her. We had a gentleman with spinal cord injury who talked about how technology had evolved over his lifetime. And it was just really lovely to see how much technology had advanced in the 20 or 30 years since his spinal cord injury. And also someone who was born with cerebral palsy talking about how he used technology in his everyday life. So I really do think it is about awareness of the possibilities.
Great. Yeah, I think it is also like, even for, we have mentioned like assistive technology for patients or people with disability, but sometimes it's just an accident, touch wood, we may have accident, and sometimes it may help us as well. So that is something that it calls the whole general public. It could be any one of us. And one more, I think there's one more question from the floor as well. So as you mentioned, the electronic assistive technology is not so common in rehab programs or integrated into the design. How the situation can be improved?
Yeah, that's a really good question. Again, I think it is awareness. So as I mentioned, as an OT, I am not across every single device that's out there. So I think being open to, as professionals, knowing where to go for information ourselves, you know, when there is a particular disability or challenge, for example, vision impairment, accessing your local organisations and advocacy groups that support those particular groups of people so that we can understand what is available out there. Leaning on our colleagues who have worked with people with disability previously and prescribed different devices. I think it's, and participating in those communities of practice, because what the really lovely thing is, it's a group of people who all come with different knowledge and expertise, and it's I guess a fountain of knowledge that you can tap into, and I guess bring a problem or an issue or a challenge that you're experiencing with a client, and get some feedback from that wider group around solutions that might be available. So I think just being aware of the communities of practice out there and tapping into them.
I see. And we have one question on about outcome measures and dependent variables. So rather than self-reports, measurable index of behavior would be more ecologically valid. So how do you take that?
Yeah, it's a really good question. We have had trouble measuring actual use. So as part of my PhD, we attempted to extract data from a smart home system to see how often people were using the device. But we actually found that the data we were getting was unreliable, and we weren't able to work with the technology supplier to address that. So I think it's an area for improvement. I'm not necessarily sure that we have more objective measures available yet. So I think that's an important area for future research.
Amazing, yeah. Well, there's some more questions from the floor. So would you please share some more examples on how smart home and communications technology improve the independence and privacy of disabled people?
Yeah, sure. I think it's important to understand in Australia, in the last 10 years or so, we've had this introduction of a funding scheme called the National Disability Insurance Scheme, and that was to try to level the playing field. As I mentioned, we had 88 different funders administering 109 different schemes, so 109 different organisations that could be supplying technology. So the NDIS came in to try and make that more equitable. And as part of the NDIS coming into play, we've seen people who have previously been living in aged care nursing homes with older people, people living in group homes, now having access to funding to move into their own apartments. So there's been this huge uptick in the development of apartments for people with disability, and a key component of those apartments is the delivery of smart home and communication technology. Most of these apartments have on-site support available in a separate apartment, similar to what you saw in that video with Talinga, so that they can be contacted via the emergency contact system or phone, depending on the person's preference. So I think in that way, we've been able to see a model of housing in these apartments that's now providing people with privacy rather than having to have staff located in the environment with the person. They're able to be just down the hall or on the other side of the building. They don't need to be necessarily in the room. And again, I think we've been looking at models where you may have supports located off-site completely and able to come in as needed. So I think it's just important to understand that context of these new models of housing being developed and these new opportunities for people with disability to live in their own homes and access support via technology. And just having those devices that might replace the need for someone else to complete a task. So whether it's opening the blinds, being able to raise or lower your bench tops, and control the temperature of your environment, you're not having to have someone at home with you to control those everyday things that we all need to do, which improves people's sense of choice and control, and of course their sense of privacy as well.
I see. So there is one more question on, there are some barriers for the disability when using the electronic assistive technology you mentioned. Do you have any suggestions on how these barriers be overcome?
Yeah, there's a few barriers that were identified. So I think one of them would be involving users in the design of devices and systems. So we talk about that co-design process involving people with disability with lived experience from the outset, so that we're getting their important feedback in regards to the design of assistive technologies. Again, I think it's also about not just prescribing or advising on a particular device for someone to start using. You need to make sure you're following up and and offering evaluation using those outcome measures, so you can look at what's changed since the person started using the device or the system, whether it has reached their goals, or whether they're having any troubles, and whether you need to explore alternatives. And again, I think just making funding more easily available, which we're starting to see in Australia, to level that playing field so people can have equal access to devices. Internet was also a big barrier. So in Australia, we've had the rollout of our national broadband network, again, to try and level the playing field when it comes to access to internet. So hopefully, since I've done my PhD, a lot of that work has been complete. So most homes in Australia should now be on the national broadband network and have fairly decent internet access, but making sure that your clients or any friends or family that you're supporting have that reliable internet connection as well.
Thank you, Rebecca, for our conversation and also answering our questions. I think the audience will benefit a lot. Thank you very much for your sharing.
Thank you for all of those questions, and thank you for inviting me.
Thank you.
Hey. Hello, everybody. My name is Heidi Anttila, and I come from the Finnish Institute for Health and Welfare, where I work as a senior researcher, and I'm leading the national program for technology supporting smart aging and care at home. We call it as KATI program here in Finland. And I'm telling about this program. Just shortly presenting my personnel here. We also work together with the VTT Technical Research Center in Finland. And here you see our personnel and our contact addresses if you're interested to contact us after the presentation. What I'm going to tell is about our national KATI program and examples of the renewed operation models for organizing home care services with technology. Why we needed age technology and national coordination in home care services for older people here in Finland. We have several reasons. First of all, Finland is one of the most rapidly aging countries, and the costs for services for the elderly are increasing. The expenditures have already doubled, and we are expecting even them to increase more. And we have already a shortage of professionals, and it's getting worse. It's counted that we will need 30,000 new professionals by 2030. And also the digitalization is lagging behind in the home care services. The processes and technology are not seamlessly integrated. Data is scattered and interfaces are lacking. That's why technology and AI are not used very often. Devices and services are deployed locally and often as a project basis, and that doesn't lead to permanent changes. And co-creation of manufacturers and users is sporadic. So the products and services do not always meet the needs of the users. And regions are many times looking for solutions to the same problems, but the information does not spread around them, and they formal evaluation, comparison, and operating models are lacking. So that's why we have the KATI program. Our objectives were to co-create, pilot, and deploy technologies by renewing services and operation models for living at home. We also evaluated impacts on welfare, home care personnel, and costs. And we created a new approach for national coordination and to support the cooperation between the social care and the many actors, companies that work in this field. We had 6 projects which targeted over 13,000 home care clients, 4,500 professionals. Those pilots durated 9 months, and the training that was needed was about 1 hour for the older people and 3 and 4 hours for the professionals. We have a lot of outcomes. 80 technology pilots took place. The project developed 62 new service models, and we did holistic impact evaluations. We used those models to create a new KATI model, how to develop the services, and we also developed a reference architecture that described the actors and the information systems that are needed in this case. And we developed a national coordination model to enhance the collaboration between the various parties. This was our model, what we started with. It described the service path in our services from the self-care to the home care services, and all steps that are in those services where the patient goes from home to and when they need the services, and we identified how technology could be used in all those steps in our model. So this is what we started with, and we wanted that the projects find new technologies to all the steps in this process. The projects used deployed many technologies. You can find them in this brochure, which is presenting the Finnish innovations in the field of age tech. And those technologies that I've circled were especially used in our projects and were taken into use. We evaluated the impacts of the technologies and devices and services. There were many, as I said, 80 pilots. There were many different types of technologies piloted and deployed. And the impacts of them on the work of the professionals were that they really needed new technology-assisted operating models. They gained new skills and possibilities in care. They got more information about the elderly's well-being and realization of the treatment, motivation and concrete aid, what they got. And they enabled to leave some tasks, concrete procedures as unnecessary. These technologies had also positive effects on the well-being of the people because the well-being of the professionals didn't decrease even when using many technologies. Older people found the care more meaningful. They could talk about the day's issues and support coping at home and sense of independence and security. That's what was they felt with the technology. And for the nearest ones, for the carers, the technology meant reduced worry and enabling them to care remotely. And for the costs, we found out, especially for the remote care and medicine dispensers, that they decreased the physical visits, saved driving kilometers, and prolonged the working careers because some nurses could work with the technology when they couldn't anymore work and do any physical visits. How we did this program is that we worked jointly with public, private and third sector organizations. We had a multi-perspective approach that brought organizations together. We had hand-on clinics, weekly coffee hours with the project people to discuss problems. We interviewed the regions and companies about their needs. We showcased companies' offerings. We created a technology market for the regions. We used external co-design support services for technology developers. We used an assessment method and public recommendations for digital health technology. This is what we call DigiHTA, which assess the technology before it's taken into use, its effectiveness, quality, security, and so on. We had an open online platform to share the technology experiences and best practices. And we also had an ethical scientific advisory board for ethics and sustainability, where we discussed the program all the time so that we are going into the right direction. And we had a multidisciplinary advisory group and involved many of these stakeholders I have in this picture for planning the coordination model, because our government wanted us to design a continuous model how to continue working with all these people, all these sectors to get the technologies in use in home care. So we are now aiming at a permanent coordination and cooperation for the coming years. We made a joint proposal with the stakeholders for our government, and it's suggesting that we continue the coordination, and we have many stakeholders, and these 9 measures, they propose the 9 measures what they would do in this coordination. There will be organizations that it will involve the users. There will be schools that support the companies to develop solutions for the user needs and export. They will train the professionals. There is a network for technology units and technology suppliers, and there's a model for assessing impact and effectiveness, and technology directory and annual events to share experiences, and a reference architecture for getting the AI and legislation and ethics into use. So this was our program, and now I'm going to show you some of the examples of some of the operation models and lessons learned in this project. Because as I told, the project developed actually 62 new operating models for home care daily practices to incorporate the technologies into use. So I'm showing you some of those. So first of the model I took here is that one of the projects in South Savo found out that they could take an interpreter into the home care to enable a sign language speakers, those old people who use sign language, so that they could also use their own language when they receive home care. And the nurse and the interpreter make a picture call to the client's tablet with the same technology. And there were several benefits to enabling use of sign language. So it's maintaining the linguistics and memory of the old person. It enables social contacts with loved ones. Also, it alleviates the loneliness and reduces misunderstandings of the nurse and the client. And the number of the physical visits are made just in case they now use the remote care more often. And there's a video you can see how this works in South Savo. This is a model for using pharmacotherapy for old people in home care. There is a medication dispensing robot which guides the old people to use the medicines. And the user experience is from one municipality only, because many of the municipalities use them now. But they say that taking the drug became easier and the times for taking the drug were stabilized. This is very important and reduces the risks for unsafe. Yes, and the 20 medicine. When they used 20 medicine robots, they saved over about 150 hours per month, those working hours per nurses, and also the driving kilometers. They didn't have to go so often to visit the people because they could take their own independently the medicines. In Pirkanmaa, they developed a device bag where they have technological devices in there, and they can take this back to the places where the old people gather and showcase the technology to them so they can try them on, and professionals and peer tutors can guide the old peoples how to use the devices, and they get more familiarized with the technologies. And this bag is now borrowed at service points in the area, so any old people's organization can now use it and try those technologies. There is an activating route program in daytime activities for the elderly, where the customer can see the routes presented by the program when using fitness equipment. And this was beneficial because they found that exercising more meaningful, and all the professionals also agreed that this was easy to use and good product. This was a screening tool for atrial fibrillation of the heart, which was tested in Pirkanmaa as well. And they took, during 6 months, they took 1,200 measurements during the home care visits. It could be the practical nurse or nurse. It took only a few minutes, and they could detect, identify people with atrial fibrillation and prevent stroke. So this was deemed very, very, very good technology. Sensors were tried in South Savo. There were 10 sensors installed at home for home care customers, and these sensors provided data on everyday activity. And this county used collected data via the sensors, and they did acute, proactive, technical, and knowledge management, situational analysis. And this is a model which proved very promising, and they are now using those sensors in persons where they need to know when they are concerned about their ability to be at home. Monitoring the overall picture of home care client with the GIES. GIES is an AI, artificial intelligence system, which gathers home care clients' data from the different systems and uses artificial intelligence to trigger changes to the client's condition. And nurses can see the client's overall situation in one place in an easy-to-read format. And the experiences from the professionals were that this really highlights the correct information and reliably anticipates the changes in the customer's condition and records the customer work. And the information produced by the equipment were more easily available in one place when working in the field, because the nurses nowadays have many different technologies and they should go to check them in different places. Now this system collects all the information in one place. It was easy to use, and in future they will also make it available in the nurses' phones. This model was used in one region in Satakunta, which had no technologies into use previously before the program, and then they took the technologies into use. They had this support model had monthly recurring info webinars, administrator application trainings, simulations in a smart home, and they trained technology ambassadors. So they targeted many different people. They needed to target the general audience and also train the nurses. So this supported the implementation of the technology by training the various target groups. Sorry. And there was this technology ambassador training, which trained the home care professionals and built them their competence. They had this general training, equipment training, system training, simulation, and then they had got this were named as ambassadors, which were able to enable a better rate of adoption and approval of the technologies. When these ambassadors work in the field, they also trained other nurses, practical nurses, about the technologies. And these are some of the take-home messages from Satakunta region. What is the model for successful technology deployment in home care? There should be clearly defined measurable goals. There should be centralized coordination across organizational boundaries. They used waves to deploy different technologies at the same time, but growing number of devices deployed in each wave. There has to be time for planning and implementation for the personnel prior to and during the deployment, and they need management support and motivated adoption promoters and professionals, indeed those technology ambassadors that they trained and used them. So we collected those different service models into a national model, which we called now the KATI model 2.0. And we added a part to it, which is about how to implement the technologies for old people at home. And this model is now updated with the tasks for the technology coordination that should be in place when technology are taken up. And we had, with the project, we learned that there are many tasks that need to be done in order to have the technologies in use in the service path. So these are listed now in this model. And we looked those tasks in the whole technology life cycle. You can see here in the here, like preparing for development, in the preparing phase, in the deployment phase, in the service support, in the service phase, and after use of the technology. And we listed those 9 places, how the service management, how the whole process control, how the evaluation should be taken into use, how architectural descriptions should be, the safety, and the approach, how to do the service, and the how to manage the devices and user support, how to ensure the competence, and how to communicate with the audience and with the client. I have now opened up one of the those lines here in this slide. This is perhaps one of the most important one. Is how to model the use of the technology throughout the service process. And this is a task for service designers. You have to understand the current process and identify the bottlenecks, and upon commissioning, model how to use the technology fluently as part of the organization's overall technology solutions, infrastructure, and service system. And during the operation, gather experience and feedback. And when you have the technology in use, and learn what are the bottlenecks, flexibly adapt and repair the model when new needs arise, and ensure functionality. And if the technology is taken from the use, evaluate the suitability of the operation model for the next technology, and understand the benefits and lessons learned. Some of the take-home messages from our whole program is that the best results were achieved with remote care and medication solutions. They really reduced the nurses' working hours by reducing mileage and physical home visits. Various sensor systems also proved very promising. Customers found them easy, and they increased safety and independence, and the worries of the loved ones decreased. They speeded up and helped to target the work of the professionals. Various platform solutions and artificial intelligence that can collect and combine the customer data. These projects took first steps to utilize them. And we really found out that integrating them into the home care services will be necessary for professionals to have a real-time overview of the client's situation. And also what is very important is that customer choices, which customers can use which technology. This is important. We need to know that. And training of the professionals. These have a significant impact on bringing out the benefits. And renewing the operation models may even bring the most important effects on cost control and for all the benefits to be realized. So here are some of the references you can look at. Thank you.
Hi, good day, everyone. Thank you for inviting me to give this talk. My talk today is about supporting safe and independent living for the elderly or the seniors with fall detection technology. And let me introduce myself. I think there's been an introduction already. I'm Desmond. I'm an emergency physician by training, and that's what I do as I'm still practicing as an emergency physician. And because of the patients that I saw in my emergency department, I felt that this was a big topic, and that's why I also started this startup. It's called RDI Home, of which I'm the co-founder. Yeah, so who are we actually? Just introduction to my company. We're actually quite an early stage startup, and our aim is to help seniors age in place. And you can see from the picture here, these are all the staff. We are really quite young in age as well. Looking to make a difference in the senior space. So I don't want to belabor the point. I think this is not just a Singapore problem. This is a worldwide problem, but Singapore is particularly hard hit, and the population is going to hit a super aged status in 2030, where 1 in 5 will be 65 years old and above. And this creates another problem in the sense that we have many seniors who are now single and staying alone at home. Currently, it's estimated that as of today, we have about 88,000 seniors in a small country like Singapore who live alone at home. Now, this wouldn't be a problem if they're all living well, but we know that this is not true. Seniors who stay alone are very vulnerable. And I'm not sure about Hong Kong, but in Singapore, we have every month or I would say every 2 weeks, we're going to have a newspaper article report about someone who died at home and was undetected. And I just felt that in a small country that's so urbanized, this is a really very poor way to die. So it's not that there are no solutions and no one has thought about this problem, but I do feel that the current solutions are inadequate. We have estimated 1 out of every 5 to 10 households have a call alarm system in Singapore. It may be a pull cord, it may be a press button. These alarms are typically quite hard to reach, and it's prone to false alarms because some of our seniors have dementia and they like to press the button, or they like to pull the cord, or even the grandchild can go in and press the button. And this leads to a lot of wasted resource in terms of responding to a false alarm. Now, there are wearables as well. Wearables is a big space. There's some use. I do think that there's some use for wearables. However, the downside of it is many of the seniors are not tech savvy. And for a low frequency event like a fall, it may be too much to ask them to charge a bracelet or watch every day. And actually, they may not be wearing the watch when they fall at home in the toilet at night because it's being charged, right? And of course, there's also just putting in a video camera, and this has a low acceptability rate, and there are a lot of privacy concerns. particularly in putting in sensitive areas like the toilet. So what the seniors need? Seniors need support when they're living at home alone. And I think what they want is that they want to be kept safe. They want to get help in times of emergency. They want to age in place. Many seniors, they don't want to be staying in a nursing home or even a sheltered home. They want to be staying in the place that they have been staying for in the last 2-3 decades at least, where they're familiar with the surroundings and their friends are there. And they also want to get help early to manage some of the health risks that they may have as they get older. So with that background, I want to present to you the Ready Steady system, or the RS system for short. This is a system that my company RDI Home came up with, and here it is. Okay, so what is Ready Steady or RS? It's an intelligent ambient assisted living solution where we use this radars that we get from any vendor, but we have got it from this vendor, and then we generate a system in the cloud, where there is a device management notification system and ability to detect certain alerts. And then we have an escalation protocol where there is then a response. And then we also give caregivers or the people we term as angels access to health assessment reports on how the senior is performing. So let me just go a bit more in depth. What type of technology do we use? We use this thing called millimeter wave or wave radars, and what it shows is that wave radars generate a point cloud, like something that looks like this. I'll show you in the next slide as well. And this it shows that it's very private. It doesn't collect any identifiable data. You know, you don't even know what the senior is doing. It's not just that you can't identify the senior, you don't even know what the senior is doing. It's like Wi-Fi, it works in all lighting conditions, and it covers a very wide area of coverage, about 4 to 5 meters, which for most Singapore living rooms is able to cover the whole area of the living room. And then we have to use algorithms over and above that to reduce the false alarm rate, while still preserving the fall detection accuracy. And this is a point cloud in action. So what you see here is someone who's walking, and our system actually is able to detect the points in the point clouds. We are able to follow the person walking. You can see here on the video, and then now he falls, and then we also are able to detect that the senior has fallen. Now this is just a simple illustration, of course, and there is actually a lot more complex than that, but I'm not a technical person, so I won't go into that area. Okay, so how does it work in real life? And we have deployed this in the real world. We have started with the most vulnerable group in Singapore, which are our seniors that stay in rental flats alone. And what you can see here is a radar that is very nicely put on the screen, on the ceiling. And we map out the whole house. We are able to put 3 radars that cover about 95% of small flat or small housing government rental flat, where some of these vulnerable seniors are staying. So our millimeter wave radars are actually very sensitive, overly sensitive per se, and this results in false alerts. So what we have built over and above that is a filtering algorithm where we analyze some of the supposed falls, and then we filter the falls based on various metrics that we know of. And in this case, we don't want to be alerting our social workers who are already very busy with false alerts. And so the algorithm is able to filter the alert first. And even for times when the alert goes through, the first one to be triggered is not the social worker that's looking after the senior, or the family that's looking after the senior, but the senior themselves. And the senior will be able to filter the next layer of false alerts. So this ends up as 0 false alerts being given to the caregiver. So we recognize that there are also diverse home settings. So in this case of Madam Z, she has a cat, and the cat gave us a lot of false alerts. But we were able to filter it out again because the cat is like jumping up and down, and we see dots that seem to have fallen onto the ground, and we had to build an algorithm to filter off the cat. And once again, sometimes we do trouble the senior, like on this is actually talking about every single day. So on day 15, we troubled the senior 2 times to say that they are okay, and it results in 0 alerts being given to caregiver again. So there is a need to build, you can't just install a radar and not have some kind of intelligence behind it. So what does it show us on day-to-day level? Okay, this is moving away from just falling per se. We are able to see where the senior is because it gives us presence data. This system, the RS system, gives us presence data. We're able to see the senior here as a dot, and this is how we map up the house. This is where this blue color area is where the bed is. This is where probably, okay, I'm not so familiar here, maybe where a sofa is, or maybe where their dresser is. And this is a kitchen, and this is the bathroom. And the bathroom, this is where the toilet bowl is. So at the time at about 3 a.m. or 2:52 a.m., the senior is sleeping in bed. This is how we interpret our dashboard. So this is a 24-hour heat map of this date, the 7th of April this year. And what do you see here actually? We see where the senior has been in the last 24 hours. The senior has spent particularly some time in the kitchen, and we can then therefore say that the senior has probably been cooking for themselves or getting some food. We can see the sleep patterns, how much time have they spent in bed, and we can see some toileting patterns as well. This is once again, this is a 24-hour heat map, but we can always scroll and look at individual time points when the senior is at home. So it does provide some useful information immediately as we see it, and I'll go through a case example pretty soon to show you how this information plays out. Okay, so this is a case study. Okay, this is one of my favorite seniors. He's I think he's hitting 90 years old. And he started with us on March this year. His clinical frailty score is about 5. He's considered to be high fall risk. So just a very bird's eye view of events. 12th March, we started monitoring him. 30th May, we noted that something had happened, and we got emergency services in. He was actually lying on the floor for a long time. And he was in hospital for a good half a month and spending quite a fair amount of money for the system. And then he was well, and then in July, you can see that his muscle tone is much better here. He celebrated his 85th birthday back at home. Oh, sorry, this is 85 years old. Okay, so he's not 90 years old, 85. Yeah, so I think the usefulness of functional monitoring, even with a fall system, is that we are able to see signs of deterioration even before the so-called event happens. And this is what has happened to him in April when we first installed the system. Prior to his decline, he was spending about, just a bird's eye view, about 72% of his time at home. We can do note here that the percentage here is different. And when coming into May, he would spend much more time at home and he would go out lesser. Now, if you imagine that someone is not feeling so well, it's quite natural for them to spend more time at home. So this is what happened to Mr. T at this point of time. And this was when we started detecting that he was spending inordinate amount of time at home, and that's when we alerted, even though there was no actual big fall per se, but because of the time he was spending at home, we did alert the social service agency to check in on him. And then come the fateful day where he was lying down the whole day, we said that we really need to do something, and emergency services were called in. So we managed to detect it before it happened. Of course, could we have done something to prevent it earlier? It's always learning lessons, looking backwards, right? Yeah, so I just give you some observations. We started monitoring him in April, and his time at home during the waking hours was about 54%. He went to the toilet twice at night, and this was some of his, give me a second. This was some of the time he spent in bed as well as lying down. Not entirely great if you imagine spending about 18 hours a day at home in the bed. That's not entirely fantastic as a baseline, but this is what we started with. And come in May, when he got worse, he was spending more time in bed, he was spending more time lying down, and he was spending more time at home overall. And so that was when he deteriorated and needed to be hospitalized on 30th of May. Now, the next thing that happened was in June, when he came back from hospital. And what we see here is that he was not altogether fantastic yet. He was better, no doubt, but hospitals usually discharge patients. There's a lot of pressure on hospital beds right now, and sometimes patients are discharged before they're 100% well. They have to do some of the recovery at home with some help from the hospital. So he was spending still a fair amount of time lying in bed and lying down, but he was spending more time out of the house. In fact, he was coming out of the house compared to earlier 66.7%. He was only spending 58% of time at home, which is good when we look from a senior point of view. Now, he got better and better, and of course, with the support, he got better. In July was when he really got much better, and this was one of the pictures that you saw earlier where he was really happy. He started spending even less time at home. He went to the coffee shop, he went to meet friends, he went to the Active Aging Center, which is just 1 or 2 blocks from him, and he spent less time in bed. So we can see that this is actually Mr. T functioning at his, I would say, his full capacity. So this was corroborated when his next of kin and as well as his neighbors started to tell us that he's much more happy in July, and he's meeting neighbors at the coffee shop. Yeah. So that is just one case. We have other cases to talk about, but we are in our early days so far. We have only deployed successfully, we have deployed only in 20 seniors, so it's not a very big sample size. I will be happy to report that because of the kind of technology we're using, acceptance rate is really very, very high, and everyone who has received the service is still interested in continuing the service. The radars are quite reliable, and we have very minimal downtime, and we are still continuing the technology development, the algorithms development, and this is a work in progress, and we want to look at more risk factors and more early signs of deterioration so that we can help our seniors. Yeah, so I just have 5 take-home messages at the end of this short talk. I think these are it. As the population ages, we need to look for innovative, creative solutions to prevent our seniors from being isolated at home. And one of these solutions could be millimeter wave radar systems, right? In and of themselves, they're not ready for just general usage. You need to build a filtering algorithm above it. Otherwise, you're going to have a lot of false positives, meaning that false alarms. This same system that monitors for false can also monitor for function at home, as I've demonstrated. And so far, the RS system that we have deployed has been quite well accepted, and is actually what I believe to be the most cost-effective in the market, because our radars are the cheapest. Right. So I thank you very much. My name is Desmond. Do feel free to contact me at this email address, and I'll be happy to share more with you, and we can discuss collaboration opportunities if there are any. Thank you so much.